So today we all live in the era of the internet, and needless to say, we get all this information about the different diseases and health problems and medicines also on the internet. But I think all of this information can be useful only if we get an analysis by an expert, advice from an expert on how it can actually be used for clinical practice, and also on an Indian perspective, because that is also very important. All the advice comes from across the globe, so it is the duty, it has become the necessity for experts to come up with opinions on how they can be used on an Indian perspective. And we are here with some expert advice today. So MACLEODS along with API is here through MedLive to give you the expert advice that we need. And we have with us Dr. Vinod Mittal. He is a senior consultant diabetologist and head center for diabetes and metabolic diseases at the Delhi Heart and Lung Institute, and he is also the director of Delhi Diabetes Center. He's also the advisor and past chairman of RSSDI Delhi State. It is so good to have you here with us, sir.
Thank you.
I think we should just start talking about how common is diabetic kidney disease.
Diabetic kidney disease is very common, especially in India. At the time of diagnosis of type 2 diabetes, around 40 to 50% of patients have diabetic kidney disease. In the initial stages, diabetic kidney disease is asymptomatic. So patients do not come to know. We have to do only the test to diagnose diabetic kidney disease. Various studies have shown the world over the prevalence of diabetic kidney disease is 10 to 40%.
So now that we have spoken about its prevalence, I think we should come to how we can actually diagnose the diabetic kidney disease.
Great. So to diagnose diabetic kidney disease, basically there are two parameters. One is urinary albumin creatinine excretion, UACR, and it should be less than 30 in normal people. If it is between 30 and 299, it is microalbuminuria, and if it is 300 or more, it is macroalbuminuria. The second criteria for diagnosis is eGFR, estimated glomerular filtration rate. It should be less than 60 to diagnose diabetic kidney disease. So we have to have these two parameters to diagnose diabetic kidney disease, and not the conventional serum creatinine, because when serum creatinine goes up, already 50% of both the kidneys has already been damaged. So we have to have parameters and criteria to diagnose kidney disease at an early stage, and that is by UACR and eGFR.
Doctor, also tell us what are the risk factors associated with diabetic kidney disease?
The risk factors are, one is age. As the patient grows older, the risk of diabetic kidney disease is more. Then the duration of diabetes and the severity of diabetes. The higher the sugar levels, longer the diabetes, more are the chances of having diabetic kidney disease. Then associated other comorbid conditions like obesity, dyslipidemia, hypertension, smoking, and family history of diabetic kidney disease.
Now that we've spoken all about this disease, the final thing that we would like to know is how to actually manage the diabetic kidney disease.
It's really very difficult to manage diabetic kidney disease, and now we are having more and more number of diabetic kidney disease patients, because initially the cardiovascular mortality, which used to be very high, still it is high, but it has been taken care by intervention cardiologist, and now there are more patients with diabetic kidney disease. So the most important thing is a lifestyle modification. The diet, healthy diet should be there. We should reduce salt intake, we should reduce even potassium intake, and we should have low fat in our diet. Some regular exercises should also be done. Control of blood pressure, control of lipid levels, stopping smoking, and then control of diabetes itself means hyperglycemia. Now I would like to tell, there are a number of anti-diabetic agents which are available, but we cannot give all the agents in diabetic kidney disease, because giving oral anti-diabetic agents, some of them may increase serum creatinine and may further damage the kidneys. So for example, sulfonylureas should be avoided, especially the long-acting sulfonylureas, that means glibenclamide, glimepiride, gliclazide and glipizide can be given, but in a reduced dose, and they should be avoided eGFR less than 60. Pioglitazone can be given, in the same dose, but should be avoided if patient is having fluid retention and already chances of heart failure are there. Metformin can be given up to an eGFR of 30. DPP-4 inhibitors are the choice of agents. They can be given even in the end-stage renal disease. The only thing is that we have to reduce the dose. The dose modification is required. GLP-1 analogs can be given up to an eGFR of 30. SGLT2 inhibitors can be given up to an eGFR of 45. Insulin is a good agent and it is an agent of choice again. The only problem is there is a decreased renal clearance for insulin. So we have to reduce the dose of insulin in patients with diabetic kidney disease to avoid hypoglycemia. And we should prefer rapid acting analogs compared to basal insulin in diabetic kidney disease.
Alright, so doctor, I must say that it has been so informative and we already have all this knowledge about diabetic kidney disease that's actually going to help us control and manage the disease. Thank you so much, doctor, for sharing with us.
Thank you very much.